Hello, and many thanks for the opportunity to discuss with you blood pressure targets after cardiac arrest. My name is Markus Skrivvars. I'm a professor of pre-hospital emergency medicine and intensivist working in Helsinki, Finland. I have some conflicts of interest which are outlined here. If we discuss blood pressure targets and management, it's of course a very multifaceted problem. The most obvious viewpoint is, of course, the brain and what is enough for the brain. Of course, some of these out-of-hospital cardiac arrest patients may have a right-shifted autoregulation and cerebral edema, which means that they may require slightly higher pressures than your regular ICU patient. Of course, most of these patients receive sedation and analgesia, and that will decrease blood pressures, so they will require vasopressors to maintain blood pressure. Patients receive TTM, and especially if a TTM target of 33 is used, that will cause a bit of vasoconstriction. And it may also influence the way vasopressors work, and that will influence our management strategies. Of course, one important point is the heart. On one hand, coronary perfusion may be increased, as we will see in the next couple of slides, with a higher blood pressure. But on the other hand, will that increase cardiac work and increase oxygen demand? And finally, there's the question of other organs, especially the kidneys. We know from patients with sepsis that if the patient has chronic hypertension or chronic kidney disease, patients may benefit from a slightly higher MAP target than your regular ICU patient. Regarding the two major organs that were also mentioned in the title, the brain and the heart, it's of course evident that hypoxic brain injury is the main killer in these patients, and fewer die due to circulatory shock. But of course, there's an interplay between these two, and we may think that what's good for the brain is likely to be good for the heart as well, and vice versa. So thinking about the coronary perfusion, most of you will know that the coronary perfusion happens during diastole. So a longer time for the diastole will probably be good and increase coronary flow. And on the other hand, it's very much about the diastolic blood pressure, which drive the coronary perfusion gradient. So an increase in diastolic blood pressure is likely to improve coronary circulation, which may be important, especially in a patient who has coronary artery disease and has had myocardial infarction. So how do we define what's the minimally adequate MAP in these cardiac arrest patients? Well, there are some studies who've done this. This is just one, but it's one of ours that we did about 5-6 years ago. About 400 cardiac arrest patients treated in Finnish ICUs over 1 year. We included prospective data collections of factors at resuscitation, and also very, very granulated hemodynamic data, because we were able to access data directly from the patient's electronic ICU vital sign collection system. So we had more than 1 million MAP values all in all. We also had data on the use of vasopressors, and the main outcome was neurological outcome at 12 months from the event. So in essence, what we did was that we defined these different MAP levels and plotted each patient's MAP level over time up until 48 hours, and then calculated the area under these different MAP thresholds. For example, in this patient, the area under a MAP level of 60 would be conceived by adding these areas together. And then we compare these areas under these different thresholds in the patients with good outcome and poor So in essence, this is what it looked like. So for 50 millimeters of mercury, uh, levels below that, here are the areas. And then for 55, it's like this. And then by comparing these, you will see that uh, there is a significant difference with higher or larger areas for the patient with poor outcome, up until between 70 and 75 millimeters of mercury, where this statistically, where this difference disappears. So providing some indirect evidence that perhaps something around 70 is the minimally accepted map in these patients. Similar findings have been shown by the TTM investigators, as shown here. You can see on the y-axis a hazard ratio for mortality. So the higher the hazard ratio, the higher the risk of patient death. And here on the x-axis, you can see the mean arterial pressure. And you can see that if we plot the mean arterial pressure and hazard ratio association, at around something between 65 and 70, the hazard ratio approaches 1, indicating that there's no increase in mortality after that level. You can see that the hazard ratio goes down and is even a bit below 1 with higher pressures. So the question is, of course, should we target an even higher map? There are two pilot studies who've looked at that during the past few years. We did this in the Coma Care study published about 2 years ago, where we included unconscious cardiac arrest patients with ventricular fibrillation as the initial rhythm, 120 of these patients that we randomized to either a MAP target of 65 to 75 or a MAP target of 80 to 100. And we focused on the first 36 hours of ICU care. This was a pilot study, so we didn't aim to find differences in patient outcomes, but instead we looked at two biomarkers of neurological injury. So the logic behind that is that if you have an out-of-hospital cardiac arrest, you get an ischemic brain injury, and based on that, you have injury to the neurons, and these injured neurons then release biomarkers into the bloodstream that you can then measure over time. So we looked at neuron-specific NLAs or NSE, which is a marker of the neurons' cellulose, if you like, and then we also looked at neurofilament light, which is a marker of axonal injury. So the findings were that here on the left, you can see NSE over time. You can see that there's no difference in the high and the low MAP groups. But very interestingly, in NFL, the NFL levels over time were significantly higher in the low MAP group. So indicating perhaps that targeting a higher MAP may be associated with a less severe axonal injury after cardiac arrest, which may be very important. Then how about the effect on the heart? And is it really good for the heart to be flogged with noradrenaline in order to increase blood pressure? We were interested in looking at that, and we did this together with this group from Belgium by Koen Ameloot and colleagues, who in 2019 completed the NeuroProtect trial, which included a hemodynamic optimization of cerebral oxygenation and blood pressures in cardiac arrest patients. So we pooled together these two studies and looked especially at the ones with cardiac arrest, shock, and myocardial infarction. So all in all, the two studies included 235 patients, similar amounts in the two MAP groups. And from the high MAP group, we identified 58 patients with myocardial infarction, so an ST elevation or clear signs on angiography that the patient had had a myocardial infarction, and then a similar amount in the low MAP group. So how did the hemodynamics act in these two groups? Well, of course, in the high MAP group, we needed more noradrenaline over time than in the low MAP group. And of course, we were able to increase blood pressure by giving noradrenaline. So the high MAP group had a MAP of around between 85 and 90, and the low MAP group had a MAP of between 70 and 75. And very importantly, this also translated into a clear difference in diastolic pressure. So higher diastolic pressure with higher MAP targets. And importantly, this did not result in any clear increase in heart rate. So here you can see the heart rate over time. You can see that they are a little bit higher in the high MAP group, but that's not statistically significant, and there's no major sign of any major tachycardia in the high MAP group, which could be detrimental if we think about coronary perfusion. Importantly, the main finding was that with the high MAP target, troponin levels over time were significantly lower in the high MAP group compared to the low MAP group. So suggesting some form of alleviation of the myocardial injury, and definitely no sign of major harm from a cardiac perspective by giving these patients more noradrenaline after cardiac arrest. We also looked at some clinical outcomes. Here you see the higher MAP group, and here you see the lower MAP group. And for example, the incidence of new atrial fibrillation or recurrent cardiac arrest, you will see that there's no major difference. Looking at clinical outcomes, the incidence of good neurological outcome and mortality, there was no statistically significant difference. That was not expected, but if anything, the trend appeared to be favoring the high MAP group compared to the low MAP group. So finally, some conclusions. Retrospective evidence suggests that the minimal MAP that we should be targeting is 65 to 70 millimeters of mercury. There is some interesting pilot data suggesting a possible benefit with targeting higher MAPs, lower brain injury, lessened cardiac injury, but that needs to be verified in future study. And the vasopressor that we should be using, I think, is noradrenaline. It has a favorable profile, increased diastolic pressure, and lack of significant tachycardia. There are definitely more studies ongoing, and these are, of course, eagerly awaited. And with that, thank you for your attention, and happy to discuss my presentation.